So, hello friends. So, this is a huge topic which I will be breaking down into few components. So, this talk I had to give in Chhatrapati Shambaji Nagar, which was called Aurangabad before. So, this talk I had to give on 13th April. So, a very interesting sort of a talk I had to deliberate upon on record maintenance, prescription errors, transfer, consent, MLC, so on and so forth. More of administrative topics. So, So the picture you see is Daulatabad. So this was the capital that was shifted from Delhi by Muhammad bin Tughlaq in 1327. So that's the area near Aurangabad. So it's a Daulatabad. So anyway, so in this particular snippet talk, I'll be talking on prescription or record maintenance rather. So we will talk on the record maintenance, what is accepted now as a norm with regards to documentation. So with the focus on computerized physician order entry. So that's the focus it will be on. So any patient who comes to ICU, there is a workflow we follow, right? And patient comes to ICU, there is a process that we follow. What is the process? So post resuscitation and initial ICU plan is something that we need to create. So when patient comes to ICU, there are three major components. One is we have to give a supportive sort of a management to the patient, which means resuscitations. We have to stabilize the patient. Then, of course, we have to formulate the treatment plan, and then we have to put in certain measures to prevent certain complications. So these are the three major tenets for any patients who come to ICU. When we talk about support, it is about immediate sort of a life-threatening issues that are addressed by taking care of airway and by giving oxygen and taking care of ventilation, breathing, and resuscitation to optimize his hemodynamics. These are the initial three things that we do for any patients who come to ICU very sick to stabilize it. And when we talk about treatment, obviously, when we base the treatment, we need to be guided by the history and clinical examination. So obviously, we need to see what is the historical sort of effects, and we have to relate this with clinical examination. Use our clinical examination or clinical acumen, and then have a differential diagnosis. And then you have to create a diagnostic workup, which means you will send off certain investigations, which includes lab, microbiology, radiology, ECG, so on and so forth, and try to identify and stratify the patients in your ICU who is the sickest, and then you will put in the treatment measures and preventative measures. This is the general workflow in an ICU. In any ICU, this is the workflow. So in ICU, I ask all my trainees, how is it different to internal medicine or anesthesia? Because there are three important components that we do in ICU. We do clinical examination, which means history, we examine the patients, we collate all the clinical findings, and then we look at the monitored variables and we look at all the gadgets that patient is connected to. In that way, it is little different to internal medicine because patients are connected to monitor, maybe connected to ventilator, maybe connected to dialysis machine, maybe connected to all the infusion pumps. So we have to collate that information, and then we integrate all the lab parameters, which is biochemistry, hematology, radiology, ECGs, and microbiology. So this is what is ICU about. So we keep on integrating the clinical findings with the monitored variables, with the investigative modalities or investigative variables. We keep on integrating this and then formulate the plan of treatment. This is what ICU is all about, isn't it? I mean, this is what is ICU. So when we're doing all this, obviously we need to do documentation. So now the current norm is computerized physician order entry is something that has been emphasized. And 2004, Bush said electronic health record is mandatory for every American by 2014. So he made this announcement in 2004 saying that all the medical records have to be in the electronic format. And this led to the evolution or emphasizing the importance of computerized entry or computerized documentation of all the facts of a patient. And in 1994, Sittig and Stead, they formulated or they put in place computerized physician order entry. Although it involved cost, but they found that it had a bearing on minimizing significant cost and ascertaining absolute safety whilst administrating medications or investigations. And this was the computerized physician order entry structure that we had in our ICU where we work. This was an old format. Now we have a newer format. So this is the Care 21 format that we had in the ICUs that we were working in. So what is the aim? Why do we need computerized physician's order entry as opposed to the paper that we were using, paper or books or whatever case files that we were using? So it is found that computerized physician order entry ensures that the clinical care is much safer and it ensures high quality care that can be delivered. So the key advantages of computerized physician order entry is to have a checklist to minimize the errors that one sort of encounters while managing the patients, and it helps you to freely make defined order choices. So these are some of the distinct advantages. And when you have a computer-based sort of an order entry of investigations or drugs, so there are certain alarms that are which are embedded, which tends to pop up and tell you that this patient is allergic to this drug, or if there is any scheduled drug or certain detailing of the drug. So alarms are given to indicate to you. It gives you the decision algorithm which helps you to make a preferred choices when you're selecting a drug. So there are certain pop-ups which give you certain warnings for a given patient. If someone is allergic, there are allergic drugs that are already collated in the system. It tends to pop up saying this patient is allergic to this, so this possibly alternative has to be looked at, and so on and so forth. And in the computerized physician order entry, there are different drop-down menus. As you see, there is a route, instruction, precautions, special instructions. So there are these drop-down menus which will ensure the safety of administration of any drugs or prescription of any drugs for these patients. And the formats are all in a recognized format, because when you write, there is a lot of room for subjective errors in interpreting what is written. So, and the formats are standardized. So these are some of the distinct advantages of doing computerized physician order entry. And what are the disadvantages? So disadvantages is direct order entry will sort of mitigate the error screening that are meant to happen. And sometimes these pop-ups are ignored. Even though you get the pop-up, so the physicians may become resistant to these pop-ups, and that not necessarily that may be acted upon. And sometimes it takes a lot of time because you have these multiple pop-ups that you need to sort of encounter or surpass to reach to the final stage of prescription of the drug. So it may be more time consuming. And many a times you would see access to computers also can be limited, because if there are 20 patients with 20 nurses, they need 20 computers. So you may have issues with regards to having enough computers to access to do these prescription entries. So these are some of the disadvantages that one may have while adopting computerized physician order entry. So to conclude, so the computerized physician order entry is considered safer, and it helps in being consistent with the type of prescriptions that you give to the patient. It is lasting, and you have a measurable sort of a tools, because you can do an audit of certain drug prescriptions that have happened, errors that have happened, and it ensures better safety and quality, and it increases the efficiency of documentation, and it reduces even the time. So these are some of the key sort of advantages or conclusions of adopting computerized physician order entry. And if you look even in India, NABH or JCI standards do recommend and suggest there should be a computerized physician order entry to minimize the errors. So maybe in the next snippet, I will talk about the drug errors. So the way forward for most ICUs in India is to adopt computerized physician order entry, because of the distinct advantages of minimizing the uh, sort of errors with the drug prescription, and to have sort of a good audit trail of the drugs that are being prescribed. So thank you, friends. So request you all to submit your valuable work to Journal of Acute Care. Visit my website. Thank you. Thank you very much.